Sorry.
This talk is being recorded, as the announced. It's really my pleasure to welcome you to this talk by Professor Johanna Schoen from Rutgers University, entitled Birth and Death in the Nursery. This talk stems from Professor Schoen's research on the history of neonatology. Before introducing Professor Schoen fully, I want to extend some thanks, share some information, and issue a caveat. I want to thank Alyssa Martinez, Linda Hillenbrand, Sue Falsetti, and Tiara Cooper for their time and help in organizing and running this event. I also want to thank the many co-sponsors of this talk, which include the Department of Women, Gender, Sexuality Studies, the Institute for Social Science Research, the Department of History, the Department of Sociology, the Reproductive Politics Faculty Seminar, and the 5-college Reproductive Health, Rights, and Justice Certificate Program. Apropos of the certificate program, we are now accepting applications. I say we because I'm an advisor in the program. So please encourage students to apply. We have some flyers here with information about the amazing program, and our Zoom moderator, Tiara, will put some links up in the chat. And apropos of Zoom, as I mentioned, we'll be recording this talk and putting it up on the WGSS website. So I encourage you to refer students and colleagues to it. Finally, we'll be holding a small reception afterwards in this room from 5:30 to 6:30. So please do stay and enjoy the beverages and food. So with all that being said, finally, I can introduce Dr. Schoen. Johanna Schoen is professor of history at Rutgers University, New Brunswick, with an affiliation at the Institute for Healthcare Policy and Aging Research. She's the author of 2 books, Choice and Coercion, Birth Control, Sterilization, and Abortion in Public Health and Welfare in the 20th Century, and Abortion After Roe, which won the Welsh Medal of the American Association for the History of Medicine. In addition, she has edited an anthology that came out last year on abortion care as moral work, ethical considerations of maternal and fetal bodies. She is now working on a book entitled Life and Death in the Nursery on the history of neonatology. For the past decade, she has worked with abortion providers to preserve the history of legal abortion in the United States and uses clinical analysis and insights to help preserve access to abortion care. In her spare time, Dr. Schoen volunteers at Memorial Sloan Kettering Cancer Center, where she is co-chair of the Patient and Family Advisory Council, the Ethics Committee, and the LGBTQ Committee, and works on improving end-of-life conversations between clinicians, patients, and caregivers. And with all that being said, I'll now turn things over to Dr. Schoen.
Thank you so much. Well, my thanks to Kirsten for inviting me. I very much look forward to coming. I guess the one thing I would say, I wrote this talk originally because I got invited by some of the medical history faculty at Yale. So part of the reason I'm going to talk a little bit about Yale is not only because it's the first NICU, but also because I felt like I should tell them about their story. And then I practiced the talk before going to Yale. There were a lot of medical terms in there that I wasn't sure how to pronounce. So I was a little bit nervous about it. And I started practicing, and my dog was sitting there and just started barking. That after 20, just kept barking. And after 20 minutes, I was laughing so hard I had to stop. I do want to say one other thing about it. The language that I'm going to use today will sound somewhat offensive to our ears today. And I decided to stick with the language that the historical subjects are using, partly because part of it are quotes or paraphrasing, and part of it because I think it gives us, as historians, a kind of a sense of how people thought and talked about the issues that I'm going to talk about today. And that has to do in particular with language that refers to disabilities. And then the other caveat is that while the talk introduces us and somewhat celebrates the achievements of building neonatology in the late 1960s, it then turns to the practices of neonatology in the late 1960s, which are not always pretty. So I just caution that some of it, the second part is a little bit gruesome, but there's nothing I can do about it. I feel like the role of the historian is supposed to celebrate achievement but also to highlight uncomfortable discussion and events. Those of you who know me know that I do that. So in 1973, in 1973, Raymond F. Duff and A.G.M. Campbell, two pediatricians at Yale New Haven Hospital, published an article in the New England Journal of Medicine assessing how more than a decade of neonatology had benefited infants and their parents. The authors observed that in hospitals with infant intensive care units, neonatal mortality rates had fallen by half compared to hospitals without such units. But while some survivors of these units were healthy, others continued to suffer, severely handicapped by a myriad of congenital malformations that in previous times would have resulted in early death. The authors noted the new treatment options raised increasing concern about the quality of life of these severely impaired survivors and their families. The authors analyzed the medical and ethical issues physicians and families were facing as new medical technologies prolonged the lives of severely ill infants and raised questions about what neonatology had achieved, what it couldn't do, and what it shouldn't do. Duff and Campbell offered a detailed analysis of infants that had died in Yale's special care nursery. They were careful to differentiate cases in which infants had died from pathologic conditions in spite of treatment, category 1, from cases in which infants had died because clinicians had decided to discontinue treatment, category 2. A careful analysis of the 256 infants who had died from pathologic conditions despite treatment indicated that the mean length of life for these infants had been just under 5 days. 50% had died within the first 2 days of life, although one had lived for more than 2 months. 66% had died as a result of respiratory problems or complications associated with extreme prematurity, which in this case means a birth weight under 1,000 grams, and another 22% had succumbed to congenital heart disease and other anomalies. In contrast, the 43 infants in category 2 had suffered from severe impairments, usually resulting from congenital disorders. Because these infants had died after pediatricians had decided to discontinue treatment, since the infant's condition did not improve despite treatment, the infant's mean length of life was longer, 7.5 days, compared to 4.8 days of infants in category 1. While 12% had died within 48 hours, pediatricians spared no efforts in their treatment of infants in category 2. Duff and Campbell reported that clinicians labored almost 2 months over 8 infants in hopes that the infants' conditions would eventually improve. Dependent on oxygen, digoxin, and diuretics, the infants had been treated for idiopathic respiratory distress syndrome with high oxygen concentrations and positive pressure ventilation. Finally, however, clinicians had given up as the condition of the infants did not improve or worsened. Deciding to stop treatment after such prolonged attempts to save an infant could be distressing to all involved. Duff and Campbell described the case of one infant who had been born with immature lungs and after 5 months of treatment suffered from chronic pulmonary disease and was dependent on a respirator. Even on the respirator, he had difficulty breathing and was of bluish discoloration due to a lack of oxygen. In addition, the infant suffered from an enlargement of the right side of the heart as a result of the lung disease. The family had endured high expenses. The hospital bill exceeded $15,000, more than $207,000 today. The siblings were developing behavioral problems and the marriage was under strain. The nurses, parents, and physicians considered it cruel to continue and yet difficult to stop. All were attached to this child whose life they had tried so hard to make worthwhile. Such decisions, the physicians made clear, were agonizing to all involved. When physicians and parents finally decided to stop oxygen supplementation for the infant, he died in about 3 hours. 2 questions stood at the center of Duff and Campbell's considerations. how to decide which infants to treat and which not to treat, and how to decide how much input parents should have in treatment decisions. Established in the fall of 1960, the Yale Newborn Special Care Nursery was the first such unit in the country to offer sick infants and their parents a dazzling array of new technologies in one space. Its founder, Louise Gluck, born and raised in Newark, New Jersey, graduated in 1952 from the University of Chicago Medical School. After completing a rotating internship in 1953, he joined a general group practice in Harlan County, Kentucky, to pay off his medical school debts. Gluck recalled his year in Harlan County as harrowing. His patients were minors dying of cancer and silicosis, their children sick and neglected. Worse, he and his colleagues began to receive death threats after the medical group went to court on behalf of the miners and won 3 cases against the coal companies. Gluck left to spend 2 years in solo practice in Lakewood, New Jersey. In 1956, he joined Babies Hospital at Columbia Presbyterian Medical Center in New York City as a pediatric resident and fetal life fellow. There, he became the first fellow to William A. Silverman, an early giant in the field of neonatology. Assessing the state of newborn care in the late 1950s, Gluck realized that pediatricians were failing critically ill newborns. For more than 40 years, preemie nurseries had hewn to the pattern established by the French professor of obstetrics, Pierre Boudin, and Julius Heth, an early prominent Chicago pediatrician whose 1934 development of the Hess oxygen bed ignited a wave of enthusiasm for oxygen therapy. Highly skilled nurses, such as those trained by Hess's chief nurse, Evelyn Lundin, had primary control of the units. Doctors were essentially outsiders. The tiny patients were stowed in warm glass incubators and handled as little as possible. Americans approached the care of preemies in the post-war years with an aggressive optimism that reflected the national faith in science and technology. The country, with support from the government, began to direct its attention and considerable resources to deal with medical issues considered of national importance, among them the high infant mortality rate. As historians have pointed out, and William Silverman himself sharply criticized, by the 1950s, clinicians jumped from consideration of reasonable theory to application in everyday practice. But the use of untested treatments and new medical technologies had produced catastrophic results. In the 1940s and 50s, it became increasingly fashionable, for instance, to give large amounts of oxygen to preemies who, as a result of their immature lungs, had developed respiratory distress syndrome. But this had led to an epidemic in infant blindness. It wasn't until 1954 that the result of a national cooperative study among 18 hospitals indicated that the cause of blindness was too much oxygen. Stevie Wonder, by the way, was blind as a result of this treatment. Clinicians knew how to take care of premature babies who were relatively well, but didn't know how to treat severely ill newborns. The latter wound up in isolation on obstetrical or pediatric wards. Infant mortality rates among critically ill infants were high, and Gluck concluded that it was time to bring them into one space to organize their care centrally. It is difficult to overstate the structural hurdles clinicians had to overcome to establish centralized neonatal intensive care units. Intensive care across the country was isolated and fragmented, frequently consisting of a series of tiny sequestered cubicles or an isolated area filled with bulky electronic equipment. In addition, hospitals were subject to waves of staph infections, and state laws required that patients be isolated within their respective wards. You couldn't mix newborns and preemies, Gluck remembered. You couldn't mix medicals and surgicals. You couldn't mix outborns and inborns. And if there was a question of an infection, you had to send them to East Jerusalem or someplace in order to get them out of sight of anybody else. A careful review of the literature led Gluck and his colleagues to realize that the infection were not, as assumed, airborne, but spread because people failed to wash their hands and pick their noses. In 1959, after completion of his residency and fellowship, Clark moved to the Stanford University School of Medicine, where he became director of newborn services at Palo Alto Hospital. There, he set up a controlled study testing his theories of infection. Clark and his colleagues began to wash 1 out of every 3 babies in the delivery room with a disinfectant, thereby virtually eradicating staphylococcal colonization in the newborn. In 1960, Clark moved from Stanford to the Yale New Haven Medical Center to expand the existing 9-incubator premature nursery into a newborn special care unit. After implementing the same infection control measures he had tested at Stanford, he slowly scaled up the number of infants admitted. Initially, he explained, we admitted only sick infants, premature or full term, born at our own medical center. After a few months, we accepted high-risk newborns from other hospitals, then readmissions, and finally, we extended our services to all neonates with special surgical and medical problems, including infants with infectious diseases. During this period, we took thousands of cultures from infants and personnel at the unit and worked out the hand washing, gown cleaning, and skin and cord care techniques necessary to prevent cross-infection. These basic techniques were then instituted in every nursery at the medical center. Following this 14-month trial period, the hospital officially opened the newborn special care unit in January of 1962. The new unit centralized the care of infants who had previously been scattered across the hospital, where they had been cared for by nurses with no experience in infant care. Now, premature infants, as well as non-premature infants who needed special management, were moved into one area under the care of nurses and physicians specializing in the care of premature and sick newborns. Later that year, the hospital converted an adjacent obstetrical ward into a special care area, thereby adding another 13 cribs to the unit. But the biggest expansion push began after December of 1964, when a donation of $500,000 from Mrs. Eleanor Naylor Tana, together with funds from other sources, allowed for the establishment of a unit large enough to house up to 40 infants with special problems. Carefully planned to incorporate the latest design, the new unit was a marvel of modern medical technology. It featured 1 large and 3 smaller rooms built around a central nursing station. To increase efficiency, the design team reduced the space between the 40 isolates from between 30 and 50 feet to 20 feet by placing all the equipment for each isolate in the ceiling. Flexible tubes for oxygen, compressed air, suction, and multiple electrical outlets hung down from the ceiling, allowing nurses and physicians to instantaneously attach respirators, monitoring devices, and infusion pumps to the infants below. In addition, clinicians have access to a variety of standard and cardiopulmonary monitoring systems. There's something docs just don't like my In addition, clinicians had access to a variety of standard and cardiopulmonary monitoring, resuscitation instruments, including a volume-controlled respirator, a portable unit to determine blood gases, cardiac monitors, apnea alarms, as well as an open-air radiant heater crib, a prototype made by Air Shields Company, which permitted clinicians to perform procedures without worrying that infants would develop hypothermia. Windowless, the unit was located in the middle of the building. The overhead lighting and the constant hum and beeping of the medical equipment made the space loud, noisy, and bright. It reminded me of the movie Coma, one of the nurses remembered. The bodies were all suspended and they were maintained by machines. The transition of preemie nursery to NICU, journalist Jeff Lyon, in Playing God in the Nursery, observed, was inspired by parallel developments in adult medicine. The first adult intensive care unit was established in 1959 by Dr. Max Harry Wheel at Los Angeles County General Hospital. It was followed in 1962 by the first coronary care unit founded at Bethany Hospital in Kansas City. Pediatricians concluded that the concept would also work for their infant patients. The Yale New Haven Special Care Nursery emerged alongside NICUs in other medical centers in the US. In Nashville, neonatologist Mildred Stahlman established a neonatal intensive care unit at the Vanderbilt University Medical Center in 1961. Funding from the National Institute for Health to study respiratory distress syndrome allowed Stahlman to establish and equip the new facility. In other medical centers too, physicians began to experiment with the idea of neonatal intensive care units. The Hospital for Sick Children in Toronto, Royal Victoria Hospital in Montreal, University College Hospital, and Hammersmith Hospital in London, Stanford University Hospital, Boston Children's Hospital, the University of Pennsylvania, the University of California at San Francisco, and Johns Hopkins University all established NICUs in the early 1960s. With the establishment of NICUs, the treatment of premature and critically ill newborns changed from a philosophy of handling the infants as little as possible to one of aggressive treatment. Major changes in the clinical care of premature infants in the 1960s meant that clinicians could now keep their patients alive. The provision of assisted ventilation for continuous respiratory support in the mid-1960s and the development and administration of surfactant to premature infants to treat respiratory distress syndrome revolutionized the field of neonatal medicine, while the introduction of IV feeding and the development of micro-infusion pumps allowed for the feeding of extremely preterm infants. And by the end of the decade, high-caloric IV preparations were better able to meet their nutritional needs. The time had come to concentrate all these treatment options in a NICU. The establishment of clinical centers devoted to the care of premature and sick infants increased the number of infant patients, as well as the clinical problems with which infants presented. But the ability to now treat severely ill infants for whom treatment had not been available earlier also led to disagreements between physicians or between physicians and parents over appropriate treatment options. This was especially the case in situations where clinicians and parents were unexpectedly confronted with a child with congenital anomalies, such as infants born with trisomy 21 with duodenal atresia and intestinal obstruction, or infants born with myelomeningocele, MMC, the most common and most severe form of spina bifida, a congenital nervous system defect. The establishment of NICUs and special care nurseries allowed clinicians for the first time to systematically address the surgical needs of these infants, and in the course of the next 2 decades changed the clinical understanding of what could and should be done for them. Duodenal atresia is a condition in which the first part of the small bowel, the duodenum, is blocked, preventing food and fluids to pass from the stomach to the intestine. With a blockage, while the blockage is easily corrected by surgery, infants who do not receive the surgery die of starvation and dehydration. Since a third of infants with duodenal atresia have trisomy 21, the classic textbook, The Surgery of Infancy and Childhood, had advised surgeons in the 1950s to carefully evaluate all infants with duodenal atresia and to forego corrective surgery if infants showed signs of trisomy 21. Similarly, before the 1950s, the prognosis of infants with myelomeningocele, which involves varying degrees of leg paralysis and bladder and bowel impairment, was poor. Approximately 80% of children with MMC have hydrocephalus, which can result in cognitive impairment and blindness. Most died in the first few months of life of meningitis or as a result of hydrocephalus. Because of the complex medical needs of these infants, as well as the social stigma and isolation of giving birth to a child with severe disabilities, children with MMC or trisomy 21 were, until the 1950s, frequently raised in institutions. Indeed, considering the outcomes for these infants extremely poor, clinicians frequently advise parents that infants with trisomy 21 and duodenal atresia, as well as infants with myelomeningocele, be left to die. But three things changed in the 1960s. First, the birth of clinical genetics in the 1950s and 60s led to an understanding of genetic diseases. Second, a number of exposés in the 1960s highlighted terrible conditions in mental institutions and residential schools, leading activists to lobby for deinstitutionalization. After legislation in 1963 made mental retardation a federal health policy issue, the federal government adopted an approach to reduce institutional populations and offer community support. Parents, too, began to voice concerns about institutionalization, and some began to establish advocacy groups that moved children with disabilities into the mainstream. Third, advances in therapies and refinement of surgical techniques contributed to the survival and higher functioning of infants with spina bifida and other health problems. By the early 1960s, the development of antibiotics to treat meningitis and of shunts to alleviate hydrocephalus allowed physicians to aggressively treat infants with MMC. Most clinicians began to follow a policy in which infants with MMC were operated on 12 to 48 hours after birth. Survival rates for these infants rose significantly, and when 3 surgeons at Children's Hospital in Sheffield, England, reviewed the results of 526 children born between 1955 and 1962 and treated for MMC, they strongly endorsed aggressive treatment for MMC infants. And as the 1960s progressed, clinicians' attitude for infants with trisomy 21 also began to shift. By the early 1960s, the surgical correction of duodenal atresia was well established. Moreover, neonatologists found over the course of the 1960s that they were able to save infants with other medical problems who would have died a decade earlier. These changes notwithstanding, many parents continue to be wary of raising a child with severe disabilities. The rubella epidemic and the thalidomide scare in the 1960s heightened Americans' concern about bringing home an infant with a disability. Faced with caring for a severely disabled and/or intellectually impaired child, families confronted significant caregiving burdens and expenses. They struggled with social shame and isolation at a time when raising a disabled child at home was still an intensely private experience. As one neonatologist remembered, parents dreaded having retarded children. When in 1963, pediatricians at Johns Hopkins University encountered an infant born prematurely with trisomy and duodenal atresia, a debate about the treatment of the infant ensued. Worried about the impact that a child with severe disability would have on their family, including the 3- and 5-year-old siblings at home, the parents refused to sign permission for the surgery that would have corrected the duodenal atresia. The infant died 6 days later. By the early 1970s, medical files at Johns Hopkins University Hospital suggested that the 1963 infant had not been alone. Other infants born with trisomy 21 and duodenal atresia too had been left untreated and had died. Indeed, it is likely that this happened in hospitals around the country. When in 1971, Robert E. Cook, pediatrician-in-chief and chairman of the Department of Pediatrics, learned of another infant with trisomy 21 and duodenal atresia, whose parents had decided against surgery, he tried unsuccessfully to intervene. The infant died after 13 days. Dissatisfied with his faculty, some of whom had supported the parents' decision, Cook turned to the Joseph P. Kennedy Jr. Foundation, which was preparing an international symposium on human rights retardation and research, and suggested the creation of a brief documentary dramatizing the 1963 and 1971 cases to screen at the opening of the symposium. The resulting film, Who Shall Survive, one of the choices on our conscience, premiered in October of 1971. Over 9 minutes and 15 seconds, it traces the delivery of baby Joe, his diagnosis with trisomy 21 and duodenal atresia, the parents' decision not to consent to surgery, the sign on his crib indicating that he should receive nothing by mouth, and the wait until his death in the documentary 15 days later. The film highlighted the moral distress of the staff as the baby slowly starved to death. One could not come away from watching the film without the impression that what had happened here was wrong. More than any case up to that time, Who Shall Survive brought issues of end-of-life decisions involving infants with disabilities out of the back rooms of the hospital and to international attention. Over the course of the 1970s, clinicians debated the ethics of non-treatment and the clinical details surrounding these decisions. Duff and Campbell were not alone in their concern that the success of neonatology over the past decade had led to the survival of severely compromised infants who would have died a decade earlier. To focus on myelomeningocele as an example, by the early 1970s, John Lorber, one of the original authors of the 1967 recommendations to aggressively treat infants with MMC, had changed his mind. After following treated MMC survivors for 7 to 12 years, Lorber judged the human costs to patients, families, and the community as too high. While intensive treatment of spina bifida cystica in recent years has resulted in much increased survival rate, he noted in 1971, there are a large number who are so severely handicapped at birth that those who survive are bound to suffer from a combination of major physical defects. Instead, Lorber now sought to develop criteria that would allow clinicians to select when to treat and when not to treat. If we wish to spare children and their families prolonged suffering and to give better attention to those who are more likely to benefit from total care, he argued, we may have to select suitable cases for intensive treatment and others for no treatment. Throughout the 1970s and into the 1980s, medical centers in the US debated Lorber's new recommendations. Seeking to gain certainty in an uncertain environment, they collected mortality rates of infants selected for non-treatment, discussed the conditions of those who survived despite non-treatment, and tried to further refine selection criteria for non-treatment. Clinicians bemoaned the emotional suffering and chronic grief that attended the birth and survival of a deformed, retarded child, and urged careful evaluation to identify hopeless, burdensome cases before initiating expensive and life-prolonging treatment. The emotional and physical pain that we cause child patients to suffer, they concluded, must be justifiable in terms of some reasonable hope for a future happy social adjustment. But clinicians lacked a unified understanding of the meaning of future happy social adjustment. While Lorber and others had sought to ensure that infants would be able to become productive citizens, others warned against such utilitarian views. The problem remained further confounding, since untreated infants who were expected to die did not necessarily die. Indeed, physicians across the country expressed bafflement at the survival of infants selected for non-treatment. After following 75 infants at the Children's Hospital of Michigan for 18 months, for instance, a team of Detroit physicians reported an unexpectedly low mortality rate. Notwithstanding the decision not to treat, most of the infants had received some treatment during the 18 months, indicating that not all clinicians and nursing staff who cared for the infants agreed on the criteria and protocol for non-treatment. And treatment in this case really meant the administration of antibiotics if they got an infection, so they no longer died of meningitis, which is what they died before. And then if they survived that, they would also start doing shunts, which meant that it alleviated hydrocephalus. And so those two things really changed the mortality rates. In the end, the high survival rate for untreated infants strongly motivated centers to offer care to all infants with MNC. As Ian Gross, who was at the Yale Nursery, noted about the experience with MMC infants at Yale, they weren't dying, they were just ending up in terrible shape, so we changed our policy. But as Stephen Campbell's article suggested, the problem in neonatology was not really undertreatment, but overtreatment. The ordeal of Andrew Stinson is a case in point. Andrew was born on September 17, 19. This is not the right slide, I'm sorry. Oh, I'm woefully behind. Okay, I'm just going to guide you through this there real quick. So Andrew was born on December 17, 1976 at a community hospital in Bethlehem, Pennsylvania. At 800 grams and a gestational age of 24.5 weeks, he was not expected to survive. And his parents, Peggy and Robert, asked the medical staff at community hospital that no heroic efforts be made to extend his life. But a week after his birth, Andrew was transferred to the NICU at Children's Hospital of Philadelphia, a tertiary care hospital where he was placed on a respirator. Over the following 6 months, he became, in the words of his parents, hopelessly trapped in an intensive care unit where the machinery was more sophisticated than the code of law and ethics governing its use. He remained dependent on the respirator until he was finally allowed to die 6 months later. Andrew developed a range of complications as a result of the treatments he received, trying to keep him alive. Problems supporting his underdeveloped lungs and providing appropriate nourishment for an extremely premature infant characterized his medical trajectory. His inability to properly breathe on his own led his physicians at Children's to place him on the respirator, as a result of which he developed bronchopulmonary dysplasia, neonatal chronic lung disease, as well as retrolental fibroplasia, an eye disease frequently leading to blindness. The chronic lung problems in turn led to a slowing of Andrew's heart rate and a lack of oxygen in his blood. Physicians' attempts to artificially nourish Andrew were nearly as unsuccessful as their attempt to breathe for him. His unmet nutritional needs, in particular his lack of minerals, led to multiple bone fractures, as well as the development of a cleft palate. As Andrew's lungs became irreparably diseased, he developed high blood pressure and began to have seizures. When on June 10, Andrew dislodged the tube connecting him to the respirator, CHOP physicians decided not to reconnect him. He finally died on June 14, 1977. As his parents sarcastically noted, he was in effect saved by the respirator to die 5 long, painful, and expensive months later of the respirator's side effects. Devastated and furious, Peggy and Robert Stinson wrote a letter to CHOP administrators and personnel, sharply criticizing the aggressive treatment of Andrew. The story of Andrew's short, cruel, institutionalized life, they warned, is a case study in the limits and successes of modern medicine and excesses of modern medicine. In 1971, they published a book, The Long Dying of Baby Andrew, about the ordeal. In addition, they published an abridged version of their letter to the hospital in Atlantic Monthly and in 1981 in the Journal of Medical Ethics. Indeed, Andrew Stinson's case was far from exceptional. Parents across the country found that neonatologists ignored their wishes to allow their severely ill infants to die, instead resorting to coercion, threats, and court orders to treat the infants only to have them die months or even years after gruesome medical ordeals. The Stinson's complaints was followed a couple years later by similar charges from a California couple, Sue and John West, who in October 1980 gave birth to their infant son, Brian. Brian was diagnosed with trisomy 21, esophageal atresia, which is a missing esophagus, and a heart murmur. The attending physician described how the particular combination of Brian's defects were far more serious than either one would have been alone. His missing esophagus could be surgically reconstructed, but Brian would never be able to swallow normally and would constantly be in danger of choking on his food. Since trisomy 21 was associated with poor muscle tone, this further increased Brian's chances of choking. In addition, stomach acids would back up into his reconstructed esophagus. And since children with trisomy 21 are also overly susceptible to upper respiratory infection, without a properly functioning esophagus to drain normal secretions to the stomach, these fluids would back up, enter the lungs, and cause pneumonia. Finally, physical therapists warned that the reduced mental capacity of children with trisomy 21 might defeat the therapeutic process required to learn how to use the new esophagus, and that Brian's frequent hospitalizations and surgical interventions would mean that attempts at early intervention and stimulation, so crucial for children with trisomy 21, would be frustrated, indeed, might significantly set Brian back. Doubting that the long-range outcome for Brian would be good, the Wests refused to authorize the surgical repair for Brian's esophagus. The decision, John West remembers, was based on love and on the golden rule. Had they been in Brian's place, neither he nor his wife would have wanted to be kept alive. The hospital, however, disagreed with the West's refusal to consent to Brian's surgery and asked the state to bring charges under the state's child abuse laws against the Wests. The Wests were charged with willful neglect, and Brian was removed from the custody and placed under the guardianship of the state. Susan West recalled, "We watched helplessly as our baby endured multiple surgeries and a host of chronic painful maladies. Brian spent the initial months of his life attached to a nasal suction machine and was fed by a nose through a hole in his stomach by a hose. Infections became chronic. Reconstructive surgery on the esophagus was performed in 2 stages when he was a little over a year old. The process can only be described as hell for him. The wounds failed to heal properly, stomach acid backed up continuously, causing such pain and irritation that it became necessary to restrain the baby's hands and feet by tying them to the 4 corners of the crib. His new esophagus was never functional, and he became caught in a perpetual pilgrimage from nursing home to hospital and back again. Shortly after his 2nd birthday, in October of 1982, another infection of unknown origin sent him to the hospital once again. While there, he went into respiratory shock and was placed unconscious on a respirator. When he stabilized, he was severely brain damaged, blind, bleeding internally, experiencing intermittent kidney failure, and had an overwhelming infection throughout his body. On December 21, 1982, at 26 months of age and weighing only 14 pounds, Brian James West finally died. 5 days later, John and Susan West appeared on CBS's 60 Minutes to talk about their experience. And I want to add to that, I have actually been in touch with John and Susan West. I can tell you in the Q&A how I found them. But Susan West, I sent her this talk after I finished it, and she added to it by telling me that it was clearly an experiment. So they actually talked to the surgeon before the surgeon tried to reconstruct the esophagus, which, as I said, was missing. So it is not an esophageal atresia, it's a missing esophagus. And they asked the surgeon whether she had ever done a surgery like that, and she said no. And then after he died, they asked the surgeon whether she would do something like that again, and the surgeon basically said no. And then the other thing that she mentioned is that here, again, the cost, right? So the bills for his 26 months of life came to $250,000 in the 1980s, which is now close to $1 million by today's Parents were not only upset at their inability to prevent aggressive treatment of the severely ill infants, they also protested the conditions under which their infants were being treated. When in the mid-1980s, Jill Lawson learned that her premature son, Jeffrey, had been awake throughout major surgery at Children's Hospital Neonatal Medical Center in Washington, D.C., the anesthesiologist had paralyzed Jeffrey with Pavulon, a curate drug that left him unable to move, but totally conscious. Lawson raised alarm. Together with NICU parent turned health advocate Helen Harrison, Lawson and Harrison protested this practice in letters to the editor of Birth. 10 years ago, Harrison noted, our premature son, Edward, was shunted for hydrocephalus while paralyzed with curate. Although he could not move, cry, or react in any way, he could see, hear, and feel as large incisions were cut in his scalp, neck, and abdomen, as a hole was drilled in his skull, as a tube was inserted into the center of his brain and then pushed down under the skin of his neck, chest, and abdomen and implanted deep in his abdominal cavity. We were told that Edward might die or become brain damaged without the operation and that anesthesia might kill him. Besides, the doctor assured us these babies don't really feel pain. I suspected then and now know that this is just not true. To this day, our severely retarded son will allow no one to touch his head, neck, or abdomen. Even heavily tranquilized, he reacts to the simplest medical procedures or the mere sight of the hospital with violent trembling, profuse sweating, screaming, struggling, and vomiting. At a 1985 National Conference of Parents of Premature and High-Risk Infants, mothers and fathers discussed a wide array of painful medical procedures that children had been subjected to: major surgery, chest tube insertions, cut downs, all performed without painkillers, gangrene and amputations from infiltrated IVs, bones broken during chest physiotherapy, skin pulled off with adhesive tape, burns from the monitors. Added to that were the 24-hour-day bombardment with bright light and loud noise, and numerous iatrogenic afflictions from improperly evaluated therapies. If this were going on in any other setting, one mother explained, it would be called torture. Parents tried a variety of avenues to protest these practices. For the most part, however, their complaints fell on deaf ears. One mother refused to sign the consent form for her daughter's surgery after realizing that no anesthesia would be used. The operation was performed anyway, Harrison reported, and the mother was reported to local authority as an abusive parent. Lawson complained about her son Jeffrey's ordeal to the Washington, D.C. Medical Society, the Washington, D.C. Commission on Licensure to Practice the Healing Arts, and the Washington, D.C. Child Protective Services Agency, none of whom were willing to intervene since the anesthesiologist had apparently followed the standards practice. The American Board of Anesthesiology told Lawson that such cases were none of their business. And when Lawson called the federal hotline set up in 1982 after President Ronald Reagan passed so-called baby doe regulations, whose avowed purpose it was to prevent inhumane medical practices, the staff at the hotline were not interested once they learned that Jeffrey had in the meantime died. Referring to the frequent charges that parents who wanted to prevent aggressive treatment of their severely ill infants were abusing their infants, Harrison charged that the real abuse was perpetrated by medical professionals. In the past 2 decades, a great deal has been written about parents as abusers of their premature babies. The time has now come for a long, hard look at the medical abuse of newborns, especially of those babies unfortunate enough to be born prematurely. What were neonatologists and pediatric surgeons thinking when they aggressively treated these infants and failed to use analgesics and anesthesia? To start with the latter, many doctors believed that preemies did not feel pain. I don't know if I have a body of knowledge that tells me if they don't perceive or feel pain, or if there are differences from older children and adults. Dr. Willis McGill, chief of anesthesiology at Children's Hospital National Medical Center, defended the treatment of Jeffrey Lawson. While McGill admitted that some neurologists described a newborn's response to stimulus as withdrawing in pain, he suggested that this could be a simple reflex. The development of anesthesia for neonates was a recent development, McGill argued, and some infants were too fragile to tolerate anesthesia. It doesn't do any good to have a dead patient who doesn't feel pain, he quipped. Lawson also suggested that anesthesiologists followed the standard of practice when they failed to give anesthesia, and that some surgeons were unaware that they were operating on an infant without anesthesia. This apparently included Jeffrey's surgeon, who had assured her beforehand that Jeffrey would receive anesthesia. After the Washington Post reported on the experience of Jeffrey and Jill Lawson in August of 1986, the American Society of Anesthesiologists and the American Academy of Pediatrics each produced statements on the appropriate use of analgesia in neonates, and by the late 1980s, clinicians embarked on a systematic investigation of neonatal pain responses. A number of factors determined clinicians' attitude about aggressive treatment. Clinicians who had trained in the 1940s and 50s prior to the advances that characterized neonatology in the 1960s and 1970s were taught not to back off. But clinicians also noted that aggressive treatment in the 1950s meant something different than aggressive treatment 2 or 3 decades later. As one neonatologist noted about the 1940s through the 1960s, you couldn't keep a dying or dead body going for hours or days, weeks, maybe a month. As you get better at what you do, and as you were able to prolong dying, then I think you've got to start to look at what you're doing. In addition, clinicians often became caught up in the excitement of addressing clinical problems in the present while losing sight of the fact that parents worried about the long-term future. William Silverman recalled his enthusiasm as he rescued a premature infant no one expected to survive. The infant did well, and I felt like a hero. For 3 months, the survival of this infant was a sensation. I realized only later that the parents were horrified. Here was this young whippersnapper not only keeping this baby alive, but using untested methods to do so. I could not understand why they didn't see it as a glorious adventure. They were looking into the future, and I was looking at the present, and it was a very exciting present. Finally, especially after the rise of the pro-life movement and the passage of the baby doll legislation during the Reagan administration, the discussion over treatment of severely ill neonates became distorted by pro-life politics. Worried about whistleblowers and lawsuits, many neonatologists began to practice defensive medicine. Others tied their support for aggressive treatment to their own pro-life beliefs. See Everett Koop, for instance, who built the pediatric surgery service at Shaw, the hospital where Andrew Stinson had been treated, was strongly pro-life and imparted his philosophy on his service. Clinicians shied away from an open discussion about the suffering infants might endure as a result of treatment, foreclosing a consideration whether allowing an infant to die might be more humane than attempting or continuing treatment. Instead, they trivialized and oversimplified the medical problems of infants and refused to acknowledge the broad range of functionality and further health complications an infant and their families might face in the future. But as parents began to protest the treatment of their infants, some neonatologists sided with the parents and offered them an avenue to reach the larger community of neonatologists by publishing their editorials and letters to the editors in medical journals. Helen Harrison, who in 1983 published the Premature Baby book to help other parents deal with the birth of a premature infant gained the ear of both NICU parents and clinicians. She and Jill Lawson found a strong ally in John W. Scanlon, director of neonatology at Columbia Hospital for Women, as well as the editor of the journal Birth, who published their letters to the editor protesting the performance of medical procedures without anesthesia. Indeed, Scanlon, who had referred Jeffrey Lawson for surgery to Children's Hospital National Medical Center, wrote a scathing editorial entitled Barbarism, in which he took his colleagues to task. Commenting on McGill's claims that little babies don't feel nor remember pain, Scanlon noted, "This physician's ignorant comment was such a shocking revelation that I inquired among friends and colleagues whether they had ever heard anything so astounding before. To my utter amazement, several nurses and physicians indicated that yes, they had witnessed some rapidly performed neonatal surgical procedures done without the benefit of anesthesia. Unless comatose, all babies respond to noxious stimuli and possess a variety of neurobehavioral mechanisms to deal with them. This suggests that babies not only feel pain, but that they retain memory about unpleasant adverse events. Veterinarians anesthetize small animals for surgical procedures. The human newborn should at least be afforded a similar consideration." In addition, the executive editor of Perinatal Press urged his colleagues to personally assess how patients they had referred to colleagues were treated rather than assume that all was well. Dr. Gerard Lucy, the editor of the Journal of Pediatrics, too, offered support and a forum. When Harrison sent him letters of complaints she had received from other parents, Lucy published a paper. He's always early. Lucy published a paper by 10 parents of premature babies proposing a number of reforms. The messages did not go unheeded. Robert Herzlinger, who was associated with the Yale Nursery, recalled reading and discussing Robert and Peggy Stinson's accounts of their baby Andrew, as well as the articles by Helen Harrison. After Harrison's 1993 article proposed a number of principles for family-centered care, Herzlinger invited parents in his NICU to discuss the adoption of the recommendations. And while Duff and Campbell in their 1973 article were early advocates for parental involvement, the long list of neonatologists who advised and supported Harrison's recommendations 2 decades later indicates that clinicians across the country rallied for greater involvement of families. While NICUs are in some ways unique, they raise questions central to modern medicine. In an area of rapid innovation where therapies quickly move from experimental to innovative, routine and outdated, how do researchers adhere to treatment protocols and informed consent? And how do patients and family members understand and participate in clinical decision-making in a specialty where so much seems at stake and hopes are so high? And with that, I welcome your questions and suggestions. Thank you. That is George, by the way. Okay, questions? Comments? Protest.
Sarah also fields some questions via Zoom if they advise.
Yeah.
Well, I'll start. Thank you for a wonderful talk. That was fabulous and fascinating. And one of the things, so I remember the fight over the baby doe
Regulations.
hotlines. Well, and there were hotlines
Yeah.
in NICU so that the nurses could call HHS and
Yeah.
say, you know, these doctors are failing to treat. And this intense sense of scrutiny in how parents were treating. In some ways, we're going through the same conversation now around especially the very restrictive abortion laws in places like Texas and Tennessee that are saying, you know, even if So on the one hand, there are laws that prevent miscarriage care. And on the other hand, there are also sort of challenging doctors and families or parents or pregnant people who are carrying infants that won't survive, or carrying fetuses that won't survive,
Right.
or will survive for a few hours. And I was wondering if you could help me understand more about what's at stake for the Right to Life movement, whether in 1984 or now, in sort of aggressively pushing this agenda around fetuses. I feel like I have some intuitions about what it is, but I haven't really read them talking about it.
Yeah, I mean, I think one of the things that is at the core of this, particularly once you get to the political part of it, right? And really the arguments made in the pro-life movement is really a refusal to confront what it means to carry a severely ill fetus, a severely compromised fetus, or to give birth to such an infant. And what that means in terms of the pain that that infant will suffer. We don't talk about that. And I think pro-life politics, the pro-life part is so central to the movement that is not a discussion where they're going to go, which is of course also the reason why we never have a discussion about, you know, the clinics like the one in Albuquerque where they actually do late-term abortions for fetal anomalies and those kinds of things. I don't think that's specific to the beginning of life. I think that also happens as we get to the end of life. And clinicians and family members and patients, great hesitation to talk about what it means to die and what the suffering, what kind of suffering that might entail. But to, if in doubt, just kind of forge ahead. And also I think this is a collective decision too, right? Our collective unwillingness to understand, for instance, that if you are in the ICU and you get resuscitated, your ability to walk out of the ICU is still basically zero. So I think in general, there is really a refusal to deal with the kind of quality of life and suffering issues that have to do with, be they infants or of any age, right, that are on the verge of life and death. I realize that's not a really compelling explanation. I mean, to some extent, it doesn't really explain it. But I do think that the unwillingness to go there comes out of the pro-life politics.
No, that makes sense. The sort of liminality of life and death is not a place where they go.
Right.
It's the absolutism of what is life.
Yeah, and it
it's fetal
extends,
life, right? It's not pregnant people's
right.
lives.
And I think it's heightened for infants, right? But it also, of course, extends to services such as medical aid in dying, you know, which the pro-life movement opposes just as much, even though in that case, in all the laws that we have in all the states, at least in the US, it's so restricted that, you know, only people who can make those decisions for themselves, and they have to basically take the drugs themselves and all those kinds of things. So yeah, it has something to do with our very peculiar relationship to death and dying, I think.
Great. Thank you so much. My name is Ray. I'm from Child Medicine. And I volunteered in the NICUs. I've only worked with adults in critical care,
Yeah.
including at Hopkins, one of the nurses who did some of the research showing that these responses to pain lead to, like, sort of proving the pain response.
Yeah.
But I was struck by the role of automation in what you were sharing. And I know at least what I observed in the clinical space, you know, oftentimes this idea that there's like decision making about intervention, especially in a place where it's super incentivized to be, doing research,
Yeah.
to be innovative
Yeah,
and very techno solutions.
Yeah.
It sort of, as things become verticalized, almost everyone I constantly care response protocol.
Yeah.
It's sort of an automation in of itself.
Right.
It's like you do one thing.
Yeah.
You insert a
Yeah.
feeding tube, and then now we're gonna do
Yeah.
course this. And then almost like both humans automating and some
Yeah.
automating. And it just what you said about the 50s, 40s and 50s versus then what it looked like in the 70s and 80s.
Right.
And now, wondered if you had any reflections on automation in spaces or like that sort of the ethics even of thinking about when does decision making happen?
Yeah.
What are the accountability systems?
Yeah, I'm really interested in the ethics because I think I was trying to figure out what does that mean for an ethical framework that would be responsive to the different needs that patients have, right? And I know that that is always decried by many opponents of this as situational ethics. I would say that it is really a situation that you have to make individually for each patient and that you have to make deliberately. And I think you put your finger right on it, that the fact that this automation exists makes it very hard, especially once you have started, to then make the decision to stop and to decide when to stop. And there too, I think we see that in all levels of clinical care. But the other thing that I find really interesting, and this partly, you didn't ask this, but there's like this weird overlap. So when we get to the point where neonatologists and pediatricians are finally starting to do research on whether neonates feel pain or not, right? That is the same as the fetal pain debate.
Yeah.
And there's a very unhappy overlap because, of course, the pro-life movement wants to say the fetus does not feel pain. But of course, the parents say, oh, but as soon as they appear, they do feel pain. And it was funny because I was looking a little bit, I'm just starting to go into that direction. Well, so one of the things that happened is when I was writing this talk in March, I still didn't know where it was going. And then I discovered these parents and I discovered them in a footnote. And then I sent off a couple of emails and then suddenly they sent me materials. And then I was like, okay, my talk is going there. But that means that all the other things I haven't yet been able to explore because I was like, okay, my talk is going to these parents. But I was emailing with a friend I have who's a retired neonatologist, and I asked him about the pain debate, because clearly the research into it starts after the Washington Post piece. That is such an alarm that like suddenly the clinicians are like, oh my God, yes, we have to respond to this somehow. And they do, they start doing all this research. So he had actually published something, but it was within the context of the fetal pain debate, although you could just change the headline and it's a different context, right? And he was telling me that when that came out, people, especially in the pro-life movement, were very unhappy with him because they did point to the existence of the ability to feel pain. So I don't know, it's really complicated and it's really political.
They're trying to build now, where they claim that they developed, which I would be. But they're trying to collect all this density to say that they can build a phenotype, even when there's no actual interaction.
Yeah. Yeah.
And that they're going to deploy sensor-based pain detection systems.
Huh.
That will be then reported in the number.
Yeah.
As a sort of definitive record or parent.
That's also really disturbing.
You're working. I just really appreciate your.
Yeah, and what is interesting is in this debate, we don't look again in detail at what is the pain and the suffering that these infants endure when we try to keep them alive until they finally die at age 6 months or a year, right? Or 2 years. So I don't know, Dagmar.
Yeah, thank you.
I saw that.
Can you, A, periodize, and B, maybe explain the shift from the moment when the doctors are just so excited because the research is interesting to them?
Yeah.
They're not
doing a pro-life thing, that's not their motivation at all.
Right.
And they're disregarding parental concern,
Yes,
part of which, of course, is dealing with a massively anti-disability society. Right, so what it would mean now to have a
Right.
disabled child would be different from what it had been in the sixties.
Yeah.
Okay, but in any event, they're disregarding parental things and they want to just keep on trying and
Yeah.
trying and trying. It's just so exciting, and you have this incredible quote about, they were thinking about the future, I was thinking about the
Yeah.
present. But at what point does that morph into C. Everett Koop and his pro-life stuff? Like, help me out here, because the doctors have two very, very different reasons for keeping things going.
yeah,
One is like, they don't really give a shit about the baby.
Yeah.
They're really just having fun and the excitement of doing it.
yeah.
You have tremendous amounts of evidence of. And when does that morph into, oh my God, and this is all about preserving life, et cetera, et cetera.
I don't actually totally know. I think it begins to morph with the rise of the anti-abortion movement.
Okay, and when do you periodize that? Because
Well, I mean,
people are the periodize it right at 73.
I start around 76 with the Hyde Amendment and then really in the 80s
Okay,
with the election of Ronald Reagan.
and the baby doe thing that Lauren.
That's 82.
82.
So some of the overtreatment that I'm describing here in the protest of parents happens prior to the baby doe. And what I find particularly fascinating and really kind of shrewd of the parents is that they try to use baby doe for their own purposes. I found that really interesting.
Very, yeah.
Because baby doe is really set up to protect the infants against the parents, right? Who
Right.
says that I don't want treatment, and the parents basically try to turn it around and say, oh, we're not the problem here. They're not successful, but yes.
But they're not successful. But at what point now, where are parents at present? That's my other question for you. Like, what's this current situation? Is it different by state? Or what's the current situation in terms of parental preferences versus doctors just keep it going, keep it going?
I think it's unit by unit.
You mean every hospital?
It might even be clinician by clinician.
Yeah, that's really what I mean. Yeah, I'm sorry. It's clinician by clinician. It's a little bit unit by unit, but yeah, they can't really control everybody who works in their unit, right? Yeah.
Although
And the
a
transition,
disgruntled staff person, sorry to give you.
No, it's
a
fine.
Disgruntled anti-choice staff person might turn in a doctor who's made his or her own decision about not doing a particular treatment, right?
yeah, I have to say that I don't, so you might actually know this better. I don't know how much that is a fear today. I have a little bit the impression, so I'm actually, because it's such a new project, kind of still stuck in the late 80s. Moving slowly forward. But I get the impression that the whole bioethics debate surrounding neonatology, they come to some kind of an informal agreement within the discipline by the 90s. At which point it's like they have kind of put the baby doe threat behind them. That's not really the issue anymore. But the other thing that really strikes me is, and this is why I can't really yet answer your question, so you have to ask again in 2 years. But the other thing that really strikes me is how long it takes for parents to really have a word in the NICU. So I started interviewing the people that surround the Yale NICU, partly because of all of this. And I found, I interviewed 3 neonatologists, and then I interviewed a nurse who had that coma remark. And then I interviewed a woman who now works as a kind of like a social worker, parent advocate, but who started because she herself had babies in the NICU. She had 2 infants who were in the NICU for a long time. And so it was one of those. I started interviewing her. We spent the first 90 minutes talking about her first NICU experience. We have yet to get beyond that first, that just happened a couple of weeks ago. So I'll go back to her. But the one thing that really struck me is that that first NICU experience was in the early 2000s at Yale, which I kind of always perceive as fairly progressive in terms of parental involvement. Yet what she was describing, and part of this is medical architecture, is still that all the bassinets were in one big room, And so there was no privacy, also no privacy when there was any clinical discussion. Because you were right next to the next baby and the next parents, and that the staff discouraged parents from talking to each other. Which I thought was really interesting, because I kept saying, but there were other parents, and did you talk to them? And she said there was one other group of parents who were always there, and they eventually found each other and started organizing. But we're talking the early 2000s, right? So that it eventually switches to family-centered care, and they eventually switch to private or semi-private rooms. But that is fairly new. I would say probably within the last 10 or 15 years. And so I think both the architecture and the lack of privacy, even to breastfeeding, people didn't really breastfeed because there was no privacy to breastfeed. And she said that when she was there in the early 2000s, she still felt like a visitor. She didn't feel like part of the care team. And I think once we move to family-centered care, that happens when we move to the private or semi-private rooms and the much greater involvement of parents and the encouragement that mothers breastfeed and that they do kangaroo care and all those things that are really more intimate. And then I think parents, at least if they have the ability to come regularly to the NICU, become more involved in the care of their infants, and they get taught by the staff to do some of the regular care of the infants. And
Do you think that starts in the early 2000s?
yeah, the discourse about it starts earlier, but I think in practice, it means that the NICUs have to have the money to basically convert their space, so that takes a long time. Yes.
So I'm speaking from the perspective of a living nurse who, I would not provide NICU care, but I had some treatment stuff.
Yeah.
Taught in that environment.
Yeah.
And I also had 2 children in the NICU.
Okay, right. You tell us.
I would say that, first of all, they're still not really semi-private or private environments in the neonatal intensive care unit, unless somebody is in isolation. And then there are sometimes private spaces. What tends to be is that there is, and it has a lot to do with nursing care, because the nurse is responsible for more than one infant
Right.
in that environment.
Yeah.
So and also because if there's an emergency, everybody needs to be able to keep an eye on.
Yeah. Yeah.
And so there's still not privacy in that sense. People tend to manage with screens and things like that. To
Right.
create the illusion of privacy. There's been a lot of progress in the last 15 years. I have noticed with things like keeping the lights down in quiet environments.
Yeah.
That's changed dramatically.
But you say in the last 15 years, right? Yeah.
15 years,
Yeah.
But the issue of keeping parents from talking to each other and keeping it is a really difficult one, because people in the hospital are so intensely focused on the issue of privacy.
Yeah.
And whereas one person may feel that they're at the top, another person is impacted to bond. Another family makes it inside of an illusion. And so there are a lot of tensions that play in that.
Yeah.
Which doesn't make it more humane for anybody.
Right.
involved. But, yeah.
Yeah, that's really interesting.
I think we have some questions.
We have one from a guest on Zoom. Do you think that some of the extraordinary measures we take in the US to keep patients alive is due not just to the pro-life movement, but to people's sense of entitlement and people's refusal to acknowledge the gravity of their position? As a former NICU nurse in the late 70s and early 80s, we saw this all the time.
I want your address so I can interview. I'm not joking. Please put your email address in there. Yes, I suspect that many factors come together and that is one of them. Yeah. So the email.
Yep.
Thank
There it
you.
is.
Can you take it down?
Sure.
I will be in touch.
Absolutely.
Yes.
About the NICU, because I have no experience with it, but what you're talking about is familiar, because my mom got a father's film, and
what I recall is there's a lot of discussion of different teams are coming in and asking us for opinions and consents. So
Yeah.
it's a deal of input, but it's a very atomized and liberal input. We need to know, are we going to do something? For
Right.
you?
Right.
Are we going to do something for her, whatever it is?
Yeah.
She went for knee surgery, had a massive stroke, never woke up from a coma. And then the other issue that was also interesting is, again, and related to the doctors and nurses, it was deeply linked to legal issues, right? So that when they wanted to ask for input, the input always was from one individual person. So that they wanted to know who could give input.
Yeah.
And we function as a family, usually a very vociferous and divided family. but
Yeah.
Once, which was a family in which everything was questioned.
Yeah.
And this notion that they wanted to know, like, what should we do? Should we give more food?
Right.
I have no idea,
Yeah.
right? Should we give it this med? So
Yeah.
there's attention to involvement, but it is not related to personhood, the way I
Right.
understand Singapore life in a broader sense.
Right.
And with medical care, it's literally like each team would come in and say they're responsible for this.
Yeah.
As if the knee was disconnected
From the rest of the body. Yeah.
So when you were talking about, and the question about automation has to do very much with the notion of life, and like we were saying earlier about the issue of death, the relationship between life and death.
Yeah, and I think this gets me back to the automation, right? So the sense I get when I read the NICU, it's by organ system, right? Somebody is responsible for the lungs, and somebody is responsible for the nutrition, and somebody is responsible for some other organ system. And so there's a huge disconnect. At some point, and here I still don't know how functional they are. At some point, the hospitals, I think also in the 80s, but I don't know how common this is, they start having ethics services to kind of deal with some of these questions. But I don't know how much they're there to really resolve issues and ponder the philosophical questions, and how much they're there to protect the legal ass of the hospital.
I think they did, again, we are a very vociferous family, and again, this is it's stressful, it's painful. I talked to my mother about that since the 1970s.
Yeah.
It's happened 5 years ago, because that is what you talk about.
Yeah.
And so at some level, he's sort of asking about, well, what is going to be her quality of life, right?
Yeah.
What's going to happen to this person?
Yeah.
They cannot answer that question. And then we were saying that y'all are really not paying attention to what you're saying. They brought in the hospital administrator, who basically kept saying, I hear you, I hear you. And it's like, actually, you have no ability to hear me.
Yeah.
Because what we talking different languages.
Yeah.
Literally different languages. And so what they're interested in is, or concerned about, is are you going to be suing them?
Right.
And they could not talk to a collective. They each, like, you have to designate one person to ask.
Who was responsible? Yeah.
But then, and again, anyway, this is just, it's not about NICU, but I can imagine how this works out, and the issue of privacy versus not, where you don't want people talking to each other.
Yeah.
Because then it becomes something broader than just medical issues
Mm-hmm.
and technical issues, but something, it's a whole different worldview.
Mm-hmm.
Yeah, so, it also reminded me of something that I had blocked out entirely in my undergraduate paper on genetics. A lot of the issues that you're talking about, that I had completely blocked out.
You get to go back to the blocking now.
Yeah. And the dog completely stopped barking as soon as you start talking about it.
Something about my voice.
Thank you for this, Dr. Schoen. I mean, I have so many, but I have the privilege of talking to you later. I'm wrestling with which one to ask you.
That's the easy one.
I don't know if okay. I mean, I was struck by the fact, so I had been thinking, as we were speaking about like the foundation of the Yale NICU unit,
Yeah.
the NICHD gets founded around that same time. There's a lot of money kind of thrown at this issue. And you kept mentioning throughout the talk about the expense of these surgeries, right? And so like immediately my mind kept going to like the degree to which NICUs are money makers for hospitals, right? So, but you also mentioned that the creation of NICU units was kind of an international phenomenon, that there were there's a synchronicity, right, in the way that they happen in these places. So I guess I'm wondering whether you found so far in your research, insofar as you've looked at, what's happening in Canada or the UK, whether decision-making processes are different in countries where there's universal healthcare versus countries where there's private healthcare, where, you can charge a family $250,000
Right.
to basically do experiments on their babies.
Yes. The answer is yes. I mean, I haven't done that much comparative stuff. But one of the things I find really interesting is that Lorber and Sheffield, that's in England, right? So the state pays, so they have an incentive to look at overall costs. There is, of course, a debate about the cost of NICU care in the United States back then and now. And people do talk about the fact that we're spending a lot of money and maybe we should reallocate it to prevent premature birth or all kinds of other things. But I think, that's a question of political will. That you pointed that out really well. The health insurance doesn't start paying for NICU care until the 70s. So in the 60s, they're fairly understaffed and really expensive. And then I just read about this. I can't remember which state it was, but some state in New England first convinces its state to start footing the bill, and then the other states quickly follow. And then it becomes a moneymaker. And then they also really quickly become, they also quickly, that shift in the early 70s, become training programs because the technology is so labor intensive that you need to have a lot of people there to kind of operate all these machines and monitor these infants. And the only way you can do it in a cost-effective basis is if you train residents and interns. So that's the other kind of transformation that happens fairly early on. But those are all areas where my notion at this point is still fairly vague. Sorry.
I would interest was that what we're talking about, the rise of the pro-life in the early 80s.
Yeah.
And watching the shifting of the viability one, right? Has maybe as much as
Yeah. Yeah, that's true. Yeah, because of course the viability line is so political.
It's not moving as far as fast.
I don't think we're clear about it, and sometimes it's been a few ways as well, but if we do have time, I'm just so curious about the sort of relationship between the venues, that the experiences the parents have, their ability to translate this into something that I think is like of public interest, and then the venues that they find as vehicles.
Yeah.
Publications. So
Yeah.
Sort of curious about that, both because it's really different defining the nature of the problem space for public consideration, and probably mobilizes some bias to whose considerations are thought to be most central, and I'm sure that's racializing class and all this different as well. So then maybe that's like thinking of social scientists and sort of dependent variable mobilization. Concern going on there, and I'm curious too about like there seems to also be some sort of process that must be a part of that for these parents about identifying or becoming sort of identified with the possibilities for pain, right, through the future of, I don't know, like medical ethics, care, the politics around it. And since you mentioned the directly spoken with some of the parents who have sort of elaborated around the archive, right, of these letters, I'm just so curious whether whether these texts were sort of lived up to the intent, maybe of what the parents thought, or what other sort of consequences of the parents engaged.
Yeah, I mean, it's clear that Helen Harrison is able to really rally parents. And so she's unfortunately no longer alive. So what happened is one of the neonatologists I interviewed pointed to this 1993 article by Helen Harrison and mentioned that he read it and that he called parents. And so I was curious about the article. So I asked him, he gave me the reference and I read it. And in the footnotes was a reference to Susan and John West's unpublished manuscript. So I did a Google search. I discovered that Helen Harrison had died. I found her widower, and the only reason I could find him and ascertain that it really was her widower is because he has a very prominent art business. And so she was associated with it, with an obscure AOL email address. So I emailed him and I said, this is who I am, and do you have papers for your wife? And if so, where are they? And then I sent a letter to the West article, footnote from 93. I thought, well, I'll just try. And I basically did the same thing. And within 48 hours, I had manuscripts and responses from both of them. Her papers are at UCSF, so I'm going to go there this summer and research them. And I suspect what I will find, he had found 10 files that were still at home that he sent to my home, which I'm sure the archivists are appalled at, but I don't care. And I know, right? And the West basically sent me their manuscript. Their son had died when he was 2. They have other children. I'm actually going to meet them because they have summer home in Maine, and we drive to Maine every summer. So I invited myself to meet them, and they were by all means. Helen West's widower is, I think, excited that somebody's writing about his late wife and somebody is bringing these stories to light, as are the Wests, but he's fairly reticent. So I said, for instance, I told him that I was going to come and research her papers and said I would, if he were interested, love to meet him in person, but he didn't respond, and he has responded to other stuff. So I don't think he's interested, which is fine. So I don't know that much about her. I hope to find more in the papers. There were the Robert and Peggy Stinson of that book. I asked Susan and John West about them, and she said that they were briefly in touch and they had sent her a copy of the book that was autographed, but I can't really find them. They're somewhere in Pennsylvania still. I have the impression that Helen Harrison really does become a longtime advocate, at least for a decade, if not longer. And she must have been fortunate to immediately find clinicians who were interested in her. And Scanlon and Lucy, the two who were interested, were also editors for major journals. So the fact that they basically agreed with her then immediately meant that she and the people who attached to her, that whole parent group that was involved in the 93 article, got a hearing and got a voice and got a lot of followers who basically agreed. With Susan and John West and the Stinsons, I got the impression that their activism was somewhat limited to the moment where they responded to the care. And that CBS 60-minute thing that I mentioned, I haven't yet watched it. I have to go to the public library in New York to watch it. But they had gotten letters in response to the CBS piece. And it is clear from the letters that the person who interviewed them on CBS was very hostile and basically essentially called them murderers of their own son and stuff like that. Really terrible, because the letters respond to that. And most of them are sympathetic to the Wests, but some of them kind of agree with him. So I think the other thing that happens is, of course, when parents speak out, they too enter this really politically charged field, right? And I don't know that as a parent, after having gone through this, I would have the stomach to deal with this question. And that might actually point, yeah, I don't know. I'll ask them when I see the West, especially when I see them, and hopefully I will find other parents of that generation, but I don't know how successful I will be with that.
So we've had the rare situation of going over time with Q&A. There's clearly more that we could ask Dr. Schoen, but we have food. We have the space for another 50 minutes, so I encourage you all to stay and maybe we can continue the conversation a bit more informally, but I'd like to formally thank Dr. Schoen for this wonderful talk and for coming to be with us this afternoon.
Thank you so much for having me and thank you for the question.
You know, what strikes me is that this is also a history of the child